Good afternoon, everyone. It's a little bit after 1, and I understand that we have quite a number of people who are logged on. So I think we'll go ahead and get started. This is a town hall meeting to discuss ambulance locality with reference to ambulance services. I'm Dr. Bob Kettler, one of the CMDs, Contractor Medical Directors here at WPS, and I will be moderating today's session. The purpose of this town hall is to take comment on locality with respect to ambulance services. And that's the only topic that is in order for this session. First of all, I'm going to provide a brief overview of the process that we'll be using today. But before we do that, I would like my colleagues here at WPS to introduce themselves. We have a group that is taking comment that I think is very well qualified to hear and consider all the testimony that will be presented today. Matt, could you please start?
Sure. Thanks for having me, Dr. Kettler. My name is Matt Davis. I'm the manager of the Insight Data and Analytics team here at WPS. And I'll be focused this afternoon from the claims processing and analytics perspective on how feasible recommendations for ambulance transports and locality are in terms of what my team would be doing for analysis to determine appropriate payment for claims. So thanks, Dr. Kettler.
Thank you, Matt. Linda?
Yes, good afternoon, everybody, and thank you very much for joining. My name is Linda Oliver. I'm the clinical manager of the Medical Review and Policy Department here at WPS, and I look forward to hearing what you have to say as far as how locality impacts the actual medical review of the documentation for ambulance transport.
Thank you, Linda. And Tom?
Thank you, Dr. Kettler. Hi, everyone. I'm Tom Ryan with WPS Outreach and Education, and I am here to figure out how ambulance locality will affect our future ambulance education and if there's any changes or what Dr. Kettler is going to do. Thanks, everybody.
Thank you, Tom. Now, I'm just going to give a brief overview of the procedure that we're going to use this afternoon. Backing up a bit, a while back, WPS solicited nominations from the hospital associations and emergency medicine service associations in each state in our jurisdictions. From that, we developed a list of commenters from those who responded. As we proceed this afternoon, each commenter will have 10 minutes to provide comment. In fairness to all commenters, we will try very hard to stick to that time. I will provide notification when 1 minute is remaining. On completion of the comment, the WPS panel that just introduced themselves will have 5 minutes to ask any questions that they might have. All commenters are welcome to attend the entire session, but if your schedule requires, you may drop off and rejoin at any time during our session. Those who are not speaking will be on mute. When it is time for you to speak, Rich will unmute you. We also have quite a number of public attendees, almost 100 signed up. The public will be on mute until the time after the commenters have completed, and then we will allow some public comment depending on the amount of time that we have left. I will provide instructions for public comment at that time. Before you begin your comment, please state your name, your role, and briefly describe any conflict of interest that you may have. We are particularly interested in hearing your comments with regards to the definition of locality, but we want to hear how this may impact timely transport for patients, how this is a concept that can be applied objectively and to all suppliers within our jurisdictions, how it is something that can be easily understood by all participants in the Medicare system, and also how it can provide for responsible use of Medicare trust fund dollars. So anything you have to say that addresses those issues will be appreciated by us. With that, I'm going to turn things over to our commenters, except I just want to provide a brief description of locality as it's described in the Internet-only manual. And I believe that we'll be able to display that definition for everybody to see. But the Internet-only manual, IOM Publication 100-02, Chapter 10, Section 10.3.5, states that the term locality with respect to ambulance service means the service area surrounding the institution to which individuals normally travel or are expected to travel to receive hospital or skilled nursing services. The MACs have the discretion to define locality in their service areas. And for point of reference, WPS has chosen to define locality as within 5 miles of the nearest appropriate facility. And with that, I'm going to turn it over to our first commenter, Ms. Katie Ahrens of Life EMS Incorporated in Michigan. Ms. Ahrens?
Good afternoon. Can you hear me?
Yes.
Thank you, Dr. Kettler and fellow WPS team members. As Dr. Kettler mentioned, my name is Katie Ahrens, and I am the Vice President of Customer Access here at Life EMS Ambulance. At Life EMS, we provide service within a variety of markets, including counties which encompass 2 urban, 7 rural, and 1 super rural region within the West Michigan communities. So we are very well versed and understand how the application of locality in our mind really cannot be a one-size-fits-all approach. The question, as I understand it, and thank you for providing additional information, Dr. Kettler, on the purpose of our call today, but is really to understand whether WPS should define locality with a quantitative approach, specifically as identified the 5 miles. I do have many concerns with this method, but given the time I have today is only 10 minutes, I wanted to highlight just a few. As previously mentioned, the definition of locality, as Dr. Kettler had described, there's also an example that is provided in the Medicare Benefit Policy Manual. It is found in Chapter 10, Section 10.3.5, which it provides an example of locality as such. Mr. A becomes ill at home and requires ambulance service to the hospital. The small community in which he lives has a 35-bed hospital. 2 large metropolitan hospitals are located some distance from Mr. A's community, and both regularly provide hospital services to the community's residents. The community is within the locality of both metropolitan hospitals, and direct ambulance service to either of these, as well as to the local community hospital, would be covered. This example as written has always been my understanding of how locality would be applied, allowing the patient the ability to travel to a potentially more distant but appropriate metropolitan hospital because the members of the community regularly travel there for routine medical care. In today's healthcare market, there's just simply not enough supply to meet the demand within one set geographic location. We are seeing that many individual hospital networks now operate urgent care centers, freestanding EDs, and walk-in clinics, sometimes within less of a mile of each other. They can do so because the demand for healthcare services continues to grow at a rate much higher than that of the supply available, as we see. Applying this qualitative approach also ensures that the healthcare system is in balance. Setting an arbitrary mileage limit would create additional hospital congestion, increasing already high wait times and wall times for ambulance providers. This means they have to wait until a clinician is available to receive the patient's report, keeping them from being able to respond to additional 911 calls coming into their community. For instance, in the example Medicare provides, if the community members all sought emergency care just within their small 35-bed hospital, the system would collapse, patient care would suffer, and likely deaths would be imminent. In our rural markets alone, it is not uncommon for us to see patients that will travel 40+ miles for their primary care because of the lack of supply in their own community. Second, further at the encouragement of CMS, many healthcare systems have moved towards value-based care models that are both patient-centered with an emphasis on reducing costs through system integration, but also ensuring high quality patient measurements. These models have required hospitals, primary care physicians, and specialists to assume a financial risk for the individuals they treat. The network is then incentivized to keep the patient within their arm's reach. Thus, requiring a patient to travel outside of their network could save the plan minuscule dollars in ambulance mileage, but it could create additional risk and cost not only to the patient, but also the health plan and the system as well, if a disruption could be perceived within their care. Thirdly, patient health is most positively impacted when the patient has a meaningful relationship with their doctor and care team. They are more likely to follow their recommendations and care plans as written when they trust them. Today's patients are more than ever loyal to their healthcare brand. Removing the patient's ability to seek care from the facility of their choice, and in turn making them pay potentially a penalty and non-covered charges, could impact their ability to not only reach out to receive further emergency care, but it could also affect their quality as well. These are just a few of my concerns as it relates today to applying a specific quantitative metric to locality. Thank you again for this opportunity, and I welcome any questions.
Thank you, Ms. Ahrens. Do any of the panelists have any questions?
Hi, Dr. Keller. This is Tom. Sorry. So, sorry, Linda, I didn't mean to cut you off, but you had mentioned that there's no real way to quantitatively define it within your jurisdiction, Katie. My understanding is what you're saying to us, and I do understand that. So what type of system would you use to measure locality to say one that is, as you said, you have rural, and I know you do. I know you have super rural, and I know that your particular ambulance, you also have some more urban areas or not defined within those. How would you then, without using a quantitative measurement, how would you define it to make it practical, to make it claims processing availability, and to make it something where Linda's medical review team could look at it?
I think that's a great question, and again, I think there's not a one-size-fits-all approach because every community in which we provide service is different. We even have medical protocols and policies that dictate which facilities, can receive certain types of patient care. So for me, I don't know if there is, a specific best practice to apply a quantitative measurement or amount to the mileage itself. But, there is the means within the Medicare policy that if, a service is not covered, the provider can append the GY modifier, or they can even split the mileage themselves if it's found that the destination the patient is going to isn't the most appropriate.
Thank you.
And I wanted to thank you as well as Tom asked my question, so appreciate that.
Thank you both.
Any other questions then?
Dr. Keller, I do have one for Ms. Ahrens here. And I'm curious for your thoughts on this, Ms. Ahrens. So talking, again, I'm from the more quantitative side, and so trying to figure out how we could best do this without putting a one-size-fits-all necessarily on it. I'm curious for your thoughts on if this an opportunity for us would be to take the data that we do have for claims processed by beneficiaries, their origin, their location origins by zip code, or even smaller geographic areas from that, and determine what facilities they go to. We can aggregate that on a large scale basis, and I'm curious if that would be more akin to what you're suggesting when you said they may go 45 miles to the typical or large hospital for their care. We can potentially quantify that, and I don't know if that fits along more with what you're suggesting, or if that's still you think might be too trying to fit it to specific numbers.
I think when you're looking at specific regions, you do have to take into consideration the service area, the population, and then what type of access do they have. And so, I'm sure data analytics can always come into play when you know, I think that the big thing here is just to emphasize that even though there may be a facility that's within 40 miles of a patient's residence, that may not be the facility that is the most appropriate for them to be received by. So what we find often, you know, is we may have to go on diversion or rerouting because the wait times in the facilities may exceed it. I think putting pressure on the staff, you know, the ambulance staff that are in the ambulance that are trying to focus primarily on providing patient care in a limited amount of time that they have, having to add an additional, you know, layer to determining what is, you know, which facility should they be taking them to, and then how do they ensure that the patient understands that this facility they're going to may, you know, may be denied for that additional mileage. I just, you know, that to me, it should never be the burden of the provider to have to be concerned with you know, what that payment may look like at that time, especially as a locality only applies to emergency situations.
Thank you for that feedback.
Ms. Ahrens, do you feel that you have problems being reimbursed for transport, even though you may have documented the reason for transporting to other than the nearest appropriate facility?
As far as the mileage goes specifically, or are you speaking in general to the entire claim, both service or lines of service?
I guess I'm speaking more generally. You know, you mentioned about how, for instance, a facility may be diverting ambulances. Do you find that when that's the case, that it's something that you can easily document? And if you do document it, do you have trouble getting reimbursement? Or, you know, I'm trying to understand too exactly where some of the problems may lie.
Yeah, I mean, in our world, we live in documentation. You've heard the adage, if it's not documented, it didn't happen, or if it did happen and it's not documented, there's no way to prove it did. So yes, I do feel I can speak for my organization, we do have ways to pull documentation to show when there's diversions or reroute direction that's being provided by a facility. We often, you know, we do look at closest appropriate facility. And then again, kind of to my previous point, if there's question of coverage, then, you know, the burden can be on the provider to go ahead and apply those GY modifiers or use the AO225 non-covered mileage code as needed. Or AO888, sorry, non-covered mileage code.
Okay, thank you. Any other questions? All right, thank you, Ms. Ahrens.
Thank you.
We're a little bit ahead here, but is Ms. Vicki Bretthauer on?
Yes, I am.
Okay, our next commenter then is Ms. Vicki Bretthauer from Valley County Health System in Nebraska. Go ahead, Ms. Bretthauer.
Thank you. As you said, my name is Vicki Bretthauer. I'm the Chief Nursing Officer at Valley County Health System, and I have no conflict disclosures. I guess I'm presenting a more simplified version of what we do at our hospital. We're a small critical access hospital. We receive direct patient transports from 7 ambulance services, and these ambulance services, all but one, are at least 20 miles from our facility. So we are receiving patients at distances of over 50 or 60 miles at times. The patients are brought to our facility. We stabilize them, make the determination as to whether they need to be transferred, or we can care for them within our facility. If we do need to transfer them, we have 4 main transfer sites. 85% of our transfers go to 2 cities, both of which are approximately 70 miles from our facility, which would be the closest larger hospitals. 11% transfer to 2 cities, that are larger, and they're 160 to 175 miles from our facility. These transfers are generally for specialized care, which is unavailable at closer facilities. 4% of our transfers are to facilities which range from 88 miles to 122 miles. Most of these transfers are for patients with behavioral health diagnoses. This percentage also includes transfers in the past year to facilities outside of our routine transfer pattern. This is due to difficulty obtaining bed acceptance. With the continued staffing shortages, there are still times we have no choice but to transfer to more distant facilities for quality patient care. There is no one-size-fits-all definition to locality. As a critical access hospital with limited specialized care, we are facing bed acceptance issues and the need to transfer the patient to the appropriate level of care, which may not always be to the closest facility. Restrictive locality definitions will jeopardize quality care to our patients. Thank you.
Thank you, Ms. Bredhauer. Do the panelists have any questions?
Hi, Dr. Keller, it's Tom again. One thing that I did hear mentioned was that you transfer for medical need, which goes beyond what you would define as the nearest facility. So therefore, it would not be nearest appropriate facility. So I'm just curious, are you having a denial issue with that when you transport further, knowing that it's medically necessary? So let's say you need a specialized cardiac unit, or you need a special burn unit, or something like that that is beyond not just your facility, but the closest facility to you. Are you having trouble getting those paid? You know, because that's a different issue than necessarily locality.
No, I don't believe we are having difficulty getting those paid. We do document, and I do think that helps to show why we've bypassed a hospital that's closer.
Thank you. I wanted to make that, you know, because locality is very specific to where you would typically take them without like medical consideration, like without that extra need for that higher level of care medical consideration. So I wanted to make sure I was on the same page with you.
Thank you.
Other questions? I do have one, Ms. Bredhauer. You mentioned that there's no one-size-fits-all solution or definition for locality. Do you have any suggestions as to how we would go about defining locality? And if you want to speak just from the standpoint of the critical access hospital, okay, but if you have ideas that apply more generally in our jurisdiction, I'd like to hear those as well.
Okay, well, I guess, you know, my experience is mainly critical access hospitals. I guess, definition for locality is difficult. I would say, you know, the documentation piece that shows the necessity to take the patient to the most appropriate level of care, regardless of whether it's the closest or not. That would be probably, you know, my only suggestion is that we, rather than limit the number of miles or what we consider to be the closest facility, we look at appropriate care.
Have suggestions as to how we can, as a claims processor, make that type of determination? You know, what we need to look for either in the claim itself or in some description of the facility.
Yeah, I think, you know, in the claim, you do look for the documentation, and you know, the specialized care, I guess even the closest hospitals that are to us, or that are 70 miles from us, are not always the highest level of care that we need. They can't handle all of our traumas. They can't handle all of our CVAs or cardiology issues. So I guess we look at those types of diagnosis and fit them with the ability of the closest hospitals.
Okay, thank you. Any other questions from my colleagues?
Hi, Dr. Kettler, it's Linda. This is more of a comment or statement, not necessarily a question for Vicki, but the situation that Vicki described is how we would go about educating our staff to an ideal situation, in that you are very rural, you are over a critical access hospital, and you are doing your purpose, and that you are stabilizing that patient upon being received at your facility before transporting them. So my comment to future speakers is, in your areas, when you do have a critical access or a smaller facility that is closer than the larger facility, while the larger facility is one that most of the people in your area utilize and frequent, I'm looking for some explanation or how my staff would be able to tell how you can justify bypassing that smaller facility who could stabilize the patient just to take them to a location which they typically receive their care at. So if I would ask the speakers that will come after Vicki to kind of consider that, I can definitely explain further if you would like me to when it is your turn. But Vicki describes a very, what we would expect to see as a typical scenario, in that the smaller facility is utilized to stabilize or initially assess that patient that needs an emergent transport. How does my staff look at your documentation and justify putting that patient potentially at a greater risk by not stabilizing them at that closer facility, just because they typically receive their care at the larger facility that's another 30 miles down the road?
Any other questions or comments from my colleagues? Okay, well, thank you, Ms. Bredhauer.
Thank you.
Is Gary Miller on the line?
I am on the line. My name is Gary Miller. I'm the Executive Director of the Indiana EMS Association, and I do not have any conflict of interest statements. Indiana Code designates transportation procedures, and they require that ambulance services in Indiana take certain patients to a trauma center if the trauma center is within 45 minutes of a scene of an accident. Obviously, the speed of most interstate highways is 70 miles an hour. A vehicle traveling that 70 miles an hour over 45 minutes will transport just over 52 miles. So let's say you take an auto accident patient that fits the definition of the code above, that occurs on one of the expressways, then we feel that the distance should be 52 miles. Now, using that, considering that the 50 miles is what's required for the transportation to get to a trauma center, now we also have to take in consideration that these patients may have to be transported back to their home or back to a rehab center. And then that rehab center or home may be 20 miles or so away from where they suffered the car accident in order to have the trauma protocols kick in. And so you add the 50 miles, and then you would almost have to add 20 miles on just in order to get them back to a place that makes the most sense, rather than having these patients transported to a rehab center that may be 50 miles away from their homes. Considering that this, in addition to the trauma patients, specialty care locations are becoming more and more prominent. These are, which include but are not limited to patients needing care for stroke at a stroke center, mental health issues where we could transport them directly to a mental health facility, and patients that need STEMI interventions. The results, this results even more patients requiring a longer locality consideration. The current 5-mile halo actually contradicts the term responsible use of trust fund dollars, as it increases the number of trips that are needed and oftentimes hospital services that are being performed. I will give you an example. A patient is home recovering from surgery performed at Hospital A. He develops complications and is transported to the nearest hospital, which happens to be Hospital B. Hospital B does not have the services necessary to treat this patient, and a second transport is necessary to transport Hospital A. So that second transport becomes an additional charge. Excuse me. And before that second transport can be done, Hospital B is going to probably perform more tests and procedures to rule out anything else that would endanger the patient during the transport to the primary facility or Hospital A. In addition, the average response for an urgent interfacility transport in Indiana for 2022 was over 2 hours, which of course further increases costs to the hospital, as well as hindering patient care, and of course increases the cost for Medicare. A final goal of this policy discussion was to make sure that the policy would be easy for claim adjudicators and reviewers to apply. Setting a 50-mile radius or greater would eliminate by far the majority of claims that would need to even be looked at. And for those trips over 50 miles, the scope of their review would be much more limited, considering that they would basically only have to look for medical necessity as the primary reason for any type of review. And I'll take any questions.
Thank you, Mr. Miller. Any questions?
So, Dr. Kettler, one of the things that I heard through that statement, and specifically in that example, was that you transported to a facility who determined that they should go to a higher facility. Would the EMT have been qualified to automatically determine that that facility doesn't have that care in the first place, so therefore the transport should have been to the higher facility in the first place if properly documented, therefore being nearest appropriate facility and payable, regardless of mileage?
A good question becomes on that is, so again, on my example of a patient who had surgery at a, let's say had a transplant at another facility. I don't see anything in the regulations that would indicate that taking the patient to the original facility where the, let's say, transplant was done was a reason to skip going to a nearer facility, a closer facility. So the question there becomes, is that a reason for bypassing does that become, where the patient had a surgery, does that become a consideration as far as bypassing a closer facility?
And that's continuity of care coming from CMS, and that's not part of the locality definition. Nothing within the locality says we get to look at continuity of care. So that isn't something, and Dr. Kettler, please feel free to jump in. I'm not sure if I'm explaining this correctly, but because that's a CMS regulation, they don't allow us to say, oh, continuity of care automatically makes this one way or the other. So I don't have a good answer for that. What we're really, we have to look at is how far from a local facility do you have to transport before it's no longer considered? How do you measure that? That's what locality is. So again, when you're describing the nearest appropriate facility, and that means that this is where the patient needs to go based on their medical condition, that is not part of the locality definition. That is nearest appropriate facility, and if properly documented, would be payable.
I'm sorry, you said it would qualify?
Anytime you have to bypass a facility, whether it's a smaller facility or whatever, for a medical need, then so let's say that that facility cannot serve someone who has a certain mental health condition or is having a certain type of cardiovascular, and you know that this facility doesn't have that cardiovascular available. Give you an example. Hey, we have a cardiovascular person available, but they only do follow-up care to surgeries on Thursday, and this patient is not a surgical patient, therefore this cardiology would never see them, right? It may be more appropriate to move them to a further facility, which would meet the nearest appropriate facility. That's where we run into the definition versus nearest appropriate facility, medically necessary transport to a further facility, which again, if documented, it would be payable.
Okay.
Other questions or comments? I guess, oh, go ahead. Or I thought somebody was about to ask a question. I'd kind of like to follow on something that Tom was saying, and I think in some ways our discussion is getting a little confused. I think we're talking at times about what is the nearest appropriate facility versus the issue of locality. And I would agree with Tom. I think if, as long as transport to a facility is properly justified, that is the nearest appropriate facility then. The issue is what should be, it's been called a halo, but I guess what would be options that are available because they're considered to be within the locality. And then that gets back to what we're hoping to do, which is try to best define locality. And so I guess, oh, go ahead.
Dr. Ketter, if I could interrupt there. And so take my example earlier where we take a trauma patient, and of course the nearest facility may be 45, 50 miles away. Now we have to return that patient to a rehab center. Well, that rehab center, let's say somebody is from northern Indiana, has to go down to South Bend, 50 miles away. Now they have to go to a rehab center. Well, there should be some consideration that the rehab center closer to the family's residence should be able to be taken into consideration, because otherwise that may be 5 miles away rehab center, but the patient's living 50 miles away.
My question for that comment, Dr. Kettler, would be, how does that fall into patient or provider preference? Because the facility that could actually treat them is 5 miles away. So I understand they live further away, but the facility that's 5 miles away could treat them. So the patient prefers to be closer to their family, or even sometimes the provider prefers to have them closer to their family due to other issues. So there's a regulation that says we can't consider patient and provider preference. That's a CMS regulation. So how do we then take that and say, oh, even though this facility can treat them, this is still the locality because each transport is separate. The one to is one transport, the one from is a different transport.
So Tom, how would you handle the patient's home? Would that be considered the closest appropriate rather than a
It is a
nursing home?
very different definition, and let me explain that. So if you're talking about a nursing facility where they live, like a nursing home, that's their home residence. It is actually billed with a different modifier. So when we look at that, we do look at home different than we would look at skilled nursing facility where they're going to get medically necessary skilled care. So the definition by putting the modifiers on there helps us indicate what we're looking at within that.
So if they're going back to a nursing home for their rehab, that would be taken into consideration?
So again, if they're going back to a nursing home for medically necessary care, then it's skilled care. That's what skilled is. If they're going for domiciliary care because they live there, then that is a different situation. That's their home. So whether you use R or the, I can't remember the exact code for it, I apologize, but whether you use those, it's different. One looks at medical necessity and what's the closest facility that can treat them, and one is not looking at that. Like the patient is going home. It's a different type of situation. One is a medically necessary facility, one is where they live.
Would it make any difference if they lived there prior or if they're a new admit?
Not from a Medicare standpoint, because Medicare doesn't pay for domiciliary care and doesn't pay for transport for domiciliary care. So Medicare's transport would say to take them to the nearest appropriate SNF that could care for them. Once they're done with that care, now we're going to look at transport to a residence. And again, that residence could be in a variety of different settings.
Sure.
Other questions or comments? Okay, thank you, Mr. Miller. Is Mr. Slagle on?
Yes, I am.
Okay, Mr. Slagle, go ahead.
Good afternoon. My name is Ron Slagle. I'm the president and CEO for Emergent Health Partners. The ambulance services I represent provide emergency care in 12 Michigan counties, and I appreciate the opportunity to provide comments on the practical implications of how locality is applied and interpreted. Patients are routinely transported to hospitals that are further than 5 miles from the closest hospital based on the historic patterns of patient care. They've been doing this for many, many years. I've been in EMS over 35 years, but I do believe it's actually becoming more common for some of the reasons that Katie Ahrens spoke of earlier. Let me share you some specific examples from the communities that we serve. So in one of our communities in southern Michigan, most patients request transport to the local community hospital in the county, but 10% of the patients in this town request to be transported to another community hospital to the next town over, or wish to go to one of the tertiary care hospitals in the larger city to the west. The difference between these equates between 5 miles from to the local hospital to as much as 24 miles to the tertiary care hospital. And this really fits the example that Katie referenced earlier out of the Medicare manual. This is the perfect example of this, and this is the reality of what we experience every day. In one of our rural counties, Berry County, 13% of the patients go to the local community hospital in the county. Another 13% come to the county to their south, and 75% go to one of the tertiary care hospitals in an adjacent community. In St. Joseph County, right along the Indiana border, we have one hospital that's moving to a rural emergency hospital status. So they only have 4 beds in that hospital. And we have one other local community hospital. 68% of the patients remain in the county, while 20% travel to the tertiary care center that I referenced in earlier counties, and another 12% travel to adjacent counties in Indiana and Michigan. The difference between some of these localities of patient transports is 5 miles to the local community hospital versus 40 miles to the next adjacent town. In Branch County, 10% of the populations are transported once again to adjacent counties. But this is not just a rural issue. In the suburban Detroit market, just looking at some sample data, patients in our service area in western Wayne County, 76% are transported to a hospital 4 miles away, while another 24% are transported to 8 other hospitals in the area ranging from 10 to 18 miles away. In Monroe County, which is along the Ohio border, 42% are transported to the local community hospital, 47% to Ann Arbor in an adjacent county, and 9% into Ohio. The difference between these, once again, is between 14 and 24 miles or 25 miles when they go to Ohio. So clearly, a 5 mile halo or radius is problematic for both beneficiaries and providers. As I mentioned before, our patients, your beneficiaries, have had long established patterns of where they seek their medical care. And we do not want our paramedics and EMTs to have to inform patients that destinations that are routinely traveled to will no longer be covered by Medicare. This will lead to patient confusion, dissatisfaction, and in the midst of a medical emergency, patients and families should not be subjected to this. Now, certainly if patients are going to areas clearly outside of the normal patterns, then locality clearly does need to come into play, but these are quite uncommon occurrences. This definition impacts urban, suburban, and rural areas. You've heard it before that one size does not fit all, and these geographic implications need to be evaluated carefully to avoid unintended consequences. Simply just changing this from 5 miles to 10 miles across the board will not solve this for many communities. Locality also is not going to be documented always by the caregivers. Because the patients, if they're routinely going to those hospitals, that's how our paramedics and EMTs have been trained for decades, that if the patient is going to a common destination, then that's just part of their normal care. One question that was asked of a panel earlier, and I think I can provide an answer to it, it's not the greatest solution, but was how would WPS staff know how to ascertain locality? And unfortunately, the answer is they would need to know every geographic area and know every local medical control protocol and regulation. Because in Michigan, it's not just a physician by themselves making a determination. Our medical control authorities, which dictate EMS care, have been determined by the courts to be quasi-governmental and therefore the equivalent of law. So we have to follow those medical regulations. So a claims examiner is going to have to understand if they were truly going to apply it in each and every case. By looking at each and every case, they're going to actually have to know those medical regulations, which vary from medical control zone to medical control zone, and they would have to know the geographic patterns of each community. So the only solution I know you're asking a very difficult question of how do you interpret and implement something. Someone earlier made a comment, if you use data analytics, there certainly could be the mathematics to that, to look at the travel patterns historically over the years for patients from every zip code and community to every hospital. But although that could be done, I'm not sure practically how you would implement that into a claims processing system. But that's the only solution I could come up with, other than having charts and charts and charts for every state, every region of every state that you have to provide claims processing for. Thank you for your opportunity to present my information, and be happy to answer any questions you might have.
Thank you, Mr. Slagle. Any questions then from my colleagues?
Hi, Dr. Keller, it's Tom again. So again, we have a regulation from CMS that says we can't look at provider or patient preference. Family preference falls into that. All of these different preferences fall into that. So when you're saying local government requires, well, there's a federal regulation as well that says nearest appropriate or locality, and how we have the right to define that. So we aren't really at that point allowed to consider certain things. And I'm not saying this is one of those. We would have to legally look into that. I'm not sure of the exact regulations and how that all plays together. But so when we look at that, how is it not, or how would you use the provider preference or the patient preference? So the patient just wants to go because that's where they always go, versus the facility that could treat them. That's where the patient wants to go, is what you're saying, from what I'm hearing. And that's just because that's where they normally go.
Well, so it's not just the patient's preference. It's a two-way street, because the patient is going there because that's the hospital that normally sees patients from that area, which is the definition of locality. And that's really what I'm referencing, is it wasn't a patient just not making up out of the blue that, oh, I want to go to hospital A because I want to go to hospital A rather than hospital B. They're going because those are the hospitals that normally accept those patients from that geographic area.
And that, again, does make sense, except it's not what we're looking for is how do you quantify that? And you're saying it should be a very complex process. I'm not disagreeing with that. At the same time, you don't feel like your provider should have to document that. So how would we know that? How would we know?
I'm not saying we shouldn't have to document that. I'm just saying that I'll use the example that I first started with. So in the town where the patient says, I want to go to the tertiary care hospital in the next adjacent town, which fits exactly the definition in the CMS manual, then the paramedics and EMTs, why would they document there was an exception to locality? Because that fits the exact location of totality. It's not that we don't want we don't want to do that. The issue is, or don't feel we should have to, is that the issue is that's the very definition of locality. So why would we need to document something that exactly fits the documentation? The documentation should list the exception to that rule or that definition.
So again, we come back to a really basic question. How do you do this in a real world claims processing situation, which WPS is tasked with, and not just saying we should have, and I'll just use Linda's stuff as an example. A medical review nurse gets it in. There's no easy, like magic way to do this. So someone's getting there, have to do a lot of programming. How do you recommend that we do that? Other than, create an Excel spreadsheet or whatever. I mean, where is this coming from? Who meets that definition? Do you get to decide that? Who defines that locality? And it's a question being asked on an overall basis. Who actually defines what is normal for that? Is it, what data would you recommend pulling? That type of thing.
Well, the only data I could recommend, is looking at historic patterns of where patients that go to hospitals historically come from.
Understanding that, but right now the historic data would show that it's billed in a couple of different manners, because it's actually would be paid with our definition of locality would be billed with two different codes. So there's a bit of a discrepancy there. And just to look at data and say, well, they go 45 miles is great, but is it 45 miles north, south? Is there one that's 45 miles and 48 miles? How are we going to tie all that together? That's where I think some of the questions are coming in for locality.
And I certainly understand that question. And I guess that's really why the point of our testimony here today is I can't think of a way to do that. And certainly just creating a arbitrary number like 5 miles certainly doesn't come into account with how the practicality of it is for providers or beneficiaries with what actually happens out in the medical care that is provided in our communities. Unfortunately, I don't really have an answer for you.
Thank you. That I understand what you're saying, and I do understand that. I was just kind of trying to get down to the drill of it. So thank you.
Other questions or comments? A question that I have is Medicare is a defined benefit program. And I guess you could say one of the definitions is the nearest appropriate facility. Should there even be an exception for locality, and everything should just rest on what is the nearest appropriate facility? And if the choice is made to go elsewhere at a greater mileage, then that's just something that isn't reimbursed. We simply go by the nearest appropriate facility. What do you think about that?
I think that would probably be a nightmare for both claims, for you as a claims processor, as well as the beneficiaries, and for us as providers. because if you're in a rural area and your choice is hospital A or hospital B, that's one thing. If you're in an urban area where there are 12 hospitals within a 8 to 12 mile radius, and you're only going to pay to 8, then you're going to have those situations that Katie referred to earlier, that patients are going to go, well, I don't want to pay for that. I'm going to go to the closest hospital, and everybody ends up there. In addition to great amounts of confusion and deviation from what has happened in the past. So I think that'd be even worse than where we are now. And as another example, so closest appropriate. So on many hospitals do not have the services available each and every day, especially in the community hospitals or rural hospitals. So on Monday and Wednesday and Friday, when the neurologist is there, they would have those services, but on Tuesday, Thursday, Saturday, and Sunday, they don't. So then it's the closest appropriate hospital on those days, but not in another day. It would just be a logistical nightmare.
I'm not sure I see though how locality enters into that. That seems to me to be the nearest appropriate facility. Granted, it changes from day to day, but I don't see that as an issue of locality. So could you?
That is not an issue of locality. So maybe I misunderstood your question. I thought you had suggested we replace locality with only closest appropriate hospital. So maybe I misunderstood your question.
So that was my question.
Well, then if you did replace it, locality wouldn't apply.
That's right. There's no locality. It's strictly a matter of the nearest appropriate facility.
Yeah. So then my answer would hold that. Then how would you as a claims provider know at any given hour of the day whether that was or wasn't the appropriate hospital, as well as for services that weren't standard practice?
Dr. Kettler, can I jump in on that? So we have that today with nearest appropriate or with locality. We as a claims processor do not add it directly for locality. I'm just, that's the reality of it. Now, on the other hand, if you get pulled into a post-pay review, or if we'll make Linda's team is the example, if they pull you into a targeted probe and educate, they are going to look at those items. So there's a certain amount of faith that you're doing what you do correctly and that you're documenting it correctly. One of the things you said is what would happen if we took them all there and suddenly they don't have any more space. Okay, now that facility goes into bypass. It's no longer the nearest appropriate facility. They do not have bed, staff, and equipment available. They may not be able to take another one. So then they're in bypass. So you just put bypass facility on bypass. That tells a medical review contractor such as Linda's staff, oh, I didn't go there because, keep looking further, keep going, more miles, more miles. So either way, somehow, you're kind of need to tell us or help us understand that. And keep in mind, it's not just always we're going to review it. Not all claims are reviewed. And that's where we wind up with a little bit of a difference there. It's when we do wind up with those reviews and it's a cert, a RAC, or even our own TPE type reviews, prior authorization reviews, certain things like that. That's where we wind up with the issue that's coming up today.
Sure. And then on the bypass issue, realize hospital A can go and bypass, at least in our communities, if hospital A goes and bypass in one community, and then we start diverting to hospital B, but as soon as hospital B is full up, then both are off diversion. So the documentation of whether there are in bypass or aren't in bypass isn't always readily available, even though the hospital is overloaded, they still may not be an official bypass. So a lot of these terminologies get interchangeably used, but don't actually reflect what's actually happening to the people trying to give care at the time, both in the emergency department and in the ambulance.
Understood. So how would you know to not go to that facility? Just say, yep, patients go where you want, regardless of if it's 50 miles, because that's just, like in a rural area, that's just a more normal range versus an urban area where it's only 7 miles difference or 15 miles difference.
So I'll give you one example concretely that happens. So the hospitals, so they can better manage the system, sometimes they alternate between patients. So patient A goes to hospital A and the next patient B goes to hospital B, so they can kind of equal out the the workload and don't have patients waiting in ERs with ambulance services in the emergency department waiting to unload stretchers because there's no beds in that hospital. This is not the health system of today is complex, and I understand the challenge you're facing is how do we balance the edits that are put in the system versus what's happening in post-payment reviews. But I think we, in understanding your responsibilities, but quite frankly, some of your responsibilities at times will conflict with each other. How do you manage the best of the trust fund monies, but still still provide adequate patient care, and we apply rules uniformly? This is one of those challenges that is very, very difficult. If there is an easy answer, we'd have suggested it at minute one.
If there was an easy answer, we wouldn't need to have this session.
That's true. That's true. But I think clearly a 5 mile halo is completely inappropriate given the examples that we've given. And I understand now we kind of go, okay, if we don't have that, what do we put in its place? And I think that's going to take some more discussion.
Well, do you have anything that would start that discussion?
So I guess the question is how elaborate do you want it to be? Because I think we have providers from 4 different states, and even within our own state, even if you developed an urban, suburban, and rural components, that still may not cover all these situations in every community. So I'm not sure. I don't really have an easy place to start that conversation other than it can't be one size fits all, because that's really kind of where we are right now.
Fair enough. Other questions or comments from my colleagues? Thank you, Mr. Schlegel.
Thank you.
Our next speaker then is Dr. David Tan. Dr. Tan, are you on the line? Dr. Tan?
Dr. Tan, I see that you are currently on mute. I'm going to unmute your mic. Okay, Dr. Tan is still on mute.
Do you need some time to deal with a technical issue, Rich?
No, I've clicked on the request unmute on his side, so it's if he doesn't have a audio connection. There we go. He's lit up now.
Dr. Tan?
Dr. Tan, we are still not able to hear you. If you have a microphone, is your microphone turned on? Sometimes there's a mute button on the screen and then a switch on whatever speaking device you're on.
Test.
I just received an email from Dr. Tan that he is not hearing any audio at the moment.
Tell you what, Rich, I could move on. I believe our next speaker is on, and I could see if he's ready. If you want to try and help Dr. Tan offline, I don't know if that's possible.
Yes, I'm going to email him back.
Okay. We'll come back to Dr. Tan then. Brian Williams, I believe you're on. Are you okay with going ahead early?
Yes, sir, Dr. Kettler.
Okay, thank you. Go ahead.
Okay, good afternoon, everyone. Thank you, Dr. Kettler, WPS staff, and fellow colleagues. My name is Brian Williams. I'm the president and CEO at Levette Health, located in Parsons, Kansas, and I have no conflicts of interest to disclose. Today, I'm representing I hope the thoughts of most hospitals in Kansas. I've conferred with several of my fellow CEOs in the Kansas Hospital Association. We've also gathered input from the executive director of the Kansas Board of EMS, Joe House. And then I've talked with several hospital-based EMS services as well as community-based EMS services. I have not conferred with air services. And I go back probably to 2015. That's where our story started. And I think, Katie Ahrens, our first speaker, really alluded to the importance of rural emergency hospitals and how much really the landscape of our healthcare has changed. It started, probably over a decade ago, and then it's gotten accelerated in the last 2 or 3 years with COVID. So we have, when I moved here in 2015, we had 11 hospitals in Southeast Kansas, which is defined as 12 counties. In the 8 years that I've been here, 3 have closed. So I'd start with Mercy Hospital in Independence, Kansas, closed in 2015. And we constructed an off-campus emergency department to serve the community, which essentially extends our main campus hospital license in accordance with provider-based billing rules in 42 CFR 413.65. We went through a very elaborate process with WPS on confirming that we met all the mileage requirements and everything along with CMS. In 2018, Mercy Hospital Fort Scott closed, and Ascension did similar to what we did, is they opened an off-campus emergency department again, which extended their main campus hospital license to Fort Scott. Because of the proximity of hospitals to each other and to each of these facilities, it's created a tremendous administrative burden for both the EMS services and WPS in conducting retrospective billing audits. The reason I got involved and really was trying to help a lot of these fire-based EMS services that without the necessary reimbursement would go out of, they wouldn't be around, and then we wouldn't have patients that could be able to be transported. And I think in the beginning, there was a lot of confusion on hospital transports or transfers from an off-campus facility to the main campus, which really you can't transport because that'd be an EMTALA violation. And I think we got past that, but still those audits, during the last 3 or 4 years, retrospective, it really, if we measured it, it's increased the cost certainly of our staff and time, and I would imagine the WPS, Linda's staff. So our request is to change the definition of locality to ease the administrative burden related to retrospective billing audits only. I really don't think that's going to change the EMS service. I haven't talked to a single EMS provider that's not going to follow their local protocols, take the patient to the closest appropriate facility during an emergency. I might stop there for a second. Linda, you asked, how would staff justify, bypassing a facility? I think the EMS would document that in their paperwork. And I know Joe House has worked with you, Dr. Kettler, and, offered if we need to improve EMS documentation, they will. But anytime there's a time critical diagnosis, stroke, STEMI, trauma, and that golden time period, it'd be very appropriate to bypass a hospital that's not a trauma center if there was a closer facility, including our off-campus facilities. If they have an unstable airway and the ambulance is en route to a more distant hospital, it would be very appropriate to pull into a off-campus ER or a rural emergency hospital or critical access hospital to protect the patient's airway. So every hospital and every off-campus facility has to provide, as part of our services to Medicare, a scope of service for emergency care. And so when we opened ours in Independence, it talks about how we have observation beds and how we have the capability to comply with EMTALA and perform medical screening exams and those things. But it ends with, in summary, the Independence ED is capable of providing diagnostic and therapeutic services to all patients with the exception of those patients with the following illness, disability, or injury. Multi-system trauma unless airway stabilization is needed. active labor excluding a precipitous delivery, urgent dialysis, i.e. the patient was on dialysis when EMS was called. So that would be beyond the capabilities of our emergency, our off-campus ED. So it would be totally appropriate to transport to a more distant facility to provide definitive care for the patient. I'm sure EMS would document that. So we believe the patient should be transported to the closest appropriate hospital, and all transfers should be the same with all necessary documentation and medical records supporting the decision to transport to a more distant facility. Our request is to distinguish locality between urban and rural. As I think all the speakers have said, 5 miles seems too narrow, and no one size fits all. But I think I sent written comments. You know, what we would suggest is using 15 miles for urban and 35 miles for rural. Title 42 in the Code of Federal Regulations refers to that. Specifically, 485.610 talks about critical access hospitals within 35 miles, secondary roads available a 15-mile drive. 42 CFR 413.65 says that, you know, a facility has to be within 35 miles of the main provider to be designated as a provider base. And then Title 42 CFR 412.92, the hospital is located 15 to 20 miles from other like hospitals. So mileage, specific mileage is very much written into Title 42 and used frequently by providers. So that's our recommendation. Trying to think if I've left out anything. And really, I think, again, it started out really more problematic around off-campus, not necessarily emergency care, but then hospital transfer. And I think that's settled down, but it's really hard, you know, for the nurses to retrospectively try to look at, well, was hospital A, were they on diversionary status? Were they not on diversionary status? And I think, again, the documentation needs to be there, both clinical at the hospital and both the EMS service. But making it broader, I think would allow the nurses to not have to focus so much, and then our EMS providers focus so much on the back end a year after the fact. I think that's everything that I had, subject to your questions.
Thank you. Questions or comments from my colleagues?
I don't know whether that's good or bad, Dr. Kettler.
Well, I
do
think
think it
this
was
is just Tom. I just want to mention a couple of things. One, some of the stuff that you're mentioning is a bigger issue that we're still dealing with. So how does the specific ambulance regulation overall ride to the ETML, and how does that work together? That's still a CMS question that's pending. So I don't want you to think, oh, we're just not looking at that. That's not true. We have to take that to CMS because it's two specific regulations that seem to impede. Now, we do look at that and say, okay, well, how does that work with provider preference? Well, you can order a transport anywhere. Any hospital, any facility can order a transport anywhere they want. It's whether or not when the ambulance company and when they're doing that research, where that is the nearest appropriate facility or within that locality. So there's a variety of different factors still in play with that. So when you said it's said and done, it's really not, but it's not really this issue. Our issue isn't about I'm off campus and you're not, so therefore it's 35 miles or it's, you know, the issue is how do we define when two facilities meet the same criteria and one is 35 miles away and one is 25 miles away, and the patient says, well, I go to both of them all the time, or people in that same community do that. So it's a different, you're bringing in a lot more things that really have to do with quote unquote locality.
Yeah, so I think they're related when you get retrospective audits. So within Parsons, there's 5 hospitals that really would meet the definition, I think, in Chapter 10, 100-2, that would meet the definition for locality because patients frequently go to multiple hospitals. So I think, Medicare's made it clear on EMTALA that you really can't transport a patient. You can't transport a patient anywhere other than your main facility if it's within the capacity and capabilities. Our biggest concern, I think, is the Consolidated Appropriations Act of 2021 has brought into effect rural emergency hospitals. If we don't have uninterrupted, smooth flowing EMS transport, those things won't exist in rural communities. So the biggest concern I think that Kansas has is of the 124 hospitals that we have, 84 of them are critical access rural hospitals. And so we need transport to be able to flow unimpeded. And with all our staffing shortages, it's very difficult a year down the road to have the onerous retrospective audits when it would just seem to give more latitude for locality would make it an easier administrative process. So, I mean, I understand, yeah, it's a complicated issue, Tom. And I think you make some good points. No, I don't think the EMTALA thing is gone away. I just think Medicare, I just think Medicare's clear when it comes to ambulance transport that the patients have to go to the facility that off-campus location is operating on their hospital license, and all the obligation and all the commitments and requirements that go with it. One unified medical staff, one medical executive committee, all those things.
Yeah, and I just wanted to clarify for everyone that was listening that that is a separate item that is not part of the locality discussion. It's a separate regulation that he's talking about. So when we focus on locality, just putting that in there sometimes draws confusion to people listening.
Sure.
Other questions or comments from WPS? Okay, well, thank you, Mr. Williams, and thank you for being flexible and jumping ahead.
Thanks, Secretary.
Now, Dr. Tan, are you able to hear us and speak to us?
I am able to hear you. Are you able to hear me?
I can hear you, yes.
Oh, great.
Go ahead.
Sorry for the technical difficulties there. But thank you. Good afternoon, and again, thank you for the opportunity to comment on the definition of locality as it relates to the provision of ambulance services. My name is Dr. David Tan. I'm a professor of emergency medicine at Washington University in St. Louis, and I'm chief of the EMS division in the Department of Emergency Medicine. My disclosures include working as an EMS medical director for a number of agencies to include private, third service, as well as fire-based ambulance services. My comments today will not necessarily be from the perspective of an administrator or business manager, but from the perspective of a physician tasked with the oversight of EMTs and paramedics who answer the call for help around the clock and act as my surrogate in the pre-hospital practice of medicine when I'm not available to be at the patient's side, obviously. So while I do work ambulance shifts fairly regularly with many of my crews, it is a fraction of the time that they spend collectively in taking care of fellow human beings in need. So EMS is a practice of medicine, and a very unique practice at that, in the sense that the responding clinician must address the immediate needs of the patient while simultaneously coordinating and planning appropriate transport destination, along with performing the physical transport itself via ambulance in a safe and efficient manner. Thus, I believe that the starting point for any discussion should be from the patient perspective as we ponder desirable aspects of the definition of locality for ambulance services. probably first and foremost on the mind of any patient requiring ambulance services is their ability to recover from their illness or injury with the opportunity to convalesce such that their health is supported. But unfortunately, I think if a beneficiary must spend time in the negotiations of denied claims or the anxiety surrounding unexpected out-of-pocket expenses, time that would otherwise have been used to maintain their health or address therapeutic tasks specific to their illness or injury, then we're not supporting the best interests of the beneficiary. So such a conundrum could easily be foreseen if a MAC eliminates, for example, the beneficiary's primary hospital of choice from the definition of locality, a hospital that may previously have been covered. So I think allowing individual MACs to define locality without objective and very non-ambiguous parameters opens the patient to this unsettling possibility. Additionally, in some states like Missouri, where I'm from, the law requires ambulance services to transport patients to their destination of choice. So Chapter 190 of the Revised Statutes of Missouri stipulates that with few exceptions, patients have to be transported to the hospital of choice. So I guess consideration would have to be given as well to local laws when creating or updating any definition of locality. Oftentimes, I would say that regional and very often state level EMS committees or advisory boards exist, which I think could serve as a rich resource for Medicare administrative contractors to make sure that any definitions are clear and understandable to providers, which would make it easier for the claims adjudicators and reviewers to apply in this process. I think that choosing not to define locality at all is even worse. A worse option as allowable payment would probably resort to closest appropriate facility, again, which is probably not the best thing for our patients. So to be clear, however, and again, from the patient's perspective, it's my belief that allowing MACs to process these claims using the locality rule is good for the beneficiary, and that it allows patients who normally obtain regular medical care at their regional hospitals can shop around for care from physicians that they prefer and trust, and maybe even find the best value for them so that they're not restricted as a beneficiary to transport only to the closest appropriate facility. I think that maybe the locality rule could be improved even further if you had objective and non-ambiguous parameters defining allowable destinations in a given geographical area based on patient preferences. Again, I think a lot of this can be driven by local knowledge from various EMS regional and state level advisory boards and committees. They would also know specific time critical diagnoses that can be best managed at specific specialty hospitals. So that would ideally go into the locality definitions as they become developed. CMS has always acknowledged the responsibility to its beneficiaries to ensure that they receive quality, effective, and efficient health care. But we also know that they have to be responsible to the investor, which is the taxpayer. So I think timely transport to facilities for patients experiencing, especially the time-critical diagnoses of acute stroke, major trauma, heart attacks, should be a consideration when defining locality and allowable charges. So thank you again for the privilege of sharing just a few thoughts this afternoon. I yield back the floor.
Thank you, Dr. Tan. Any questions or comments? And I did get a message from Linda that her microphone is not working. So Linda, if you have a question, you can send it to me and I'll be glad to relay it. Dr. Tan, a question that I do have, and this might be getting away a bit from locality, but one of the things that we, I think, struggle with in the documentation is that the documentation of a physician's reasons for wanting a particular destination is not always very clear. Do you have any thoughts on how that could be improved?
Yeah, you know, I hearken back to the physician certification statements that are out there that were filled out, and I think if we need more specific direction or more specific explanations for beneficiaries to be transported to a specific hospital, that's certainly a reasonable thing to ask of the sending physician. I think it, just like so many things when it comes to billing, you know, doctors being the worst business people in the world often, it just is a matter of educating the providers and the clinicians who are filling out these forms, the physician in particular, why it's so important. Again, from the patient's perspective, one of the things that really drove home for me why it's so important to make sure that these types of forms are filled out appropriately is so that they are not saddled with otherwise eligible and bona fide bills that should be paid, that they then get stuck with a bill for out-of-pocket expenses, and they're spending their time trying to negotiate these financial difficulties in an already taxing situation, and it's not good for their recovery either. And so this is something that I've shared with my colleagues, and you know, on the ambulance side of it, my ambulance business managers asked me to be an advocate for proper documentation for billing purposes. But it really is, if you think about it, it really is for clinical purposes as well, because the patient is not therefore spending convalescent time fighting bills.
Thank you. Other questions or comments?
Dr. Tan, I'm sorry, this is Tom. Could you jump back and I missed your comment on it, and I heard you say something about diagnosis driven, but I wasn't exactly clear as to what you were saying there. So are you saying, I'll just give you an example. A patient has a cardiology diagnosis or you know, is reporting they're having a heart attack, and so the EMT treats as such, so that may be a reason to look at a different, I wasn't really sure what you were saying, sorry.
Oh, yes. No, I'm happy to clarify. The state of Missouri actually defines 3 specific diagnoses which are considered time critical, meaning it's a disease process that really does need specialty care at a specific specialty hospital. Probably the easiest one to think of is a major trauma, so a level 1 trauma. You wouldn't want to take that to the closest appropriate facility necessarily, because that facility may not have any of the resources required to treat that patient or save their life. And it's basically, you're just delaying transport to definitive care. The same can be said for acute stroke, acute ischemic stroke, and certain types of heart attacks like STEMIs, ST elevation MIs. And so those really do need to go to those facilities that can handle it best from a patient care standpoint. They can often be quite a distance away, further away, but when you think about the time saved on the front end by just getting the patient to the right facility, the definitive care, you're saving a lot of time on the back end as far as delays in transfers, delays in definitive interventions, and the like. So there are a few things which are diagnosis specific.
Perfect. I'm just kind of fielding back and forth for a couple people too, so I apologize. So that does make sense. And one of the things that you mentioned falls back to the nearest appropriate facility. So you said they may not be the best facility or they may not be equipped to treat that. Then they wouldn't be the appropriate. They may be the nearest, physical distance nearest, but we also
Correct.
have to look at bed, staff, and equipment. Now, if we look at it and we have no way of knowing they don't have that, that's where we need to rely on the ambulance supplier, whether whoever is doing that, or as an example, the PCS could also give us that and say, you need to go by these 4 facilities because they don't have this, so don't take my patient there. Okay, well, that makes sense to us then. So
Yeah.
I just want to make it clear, like locality and nearest appropriate, we kind of mix them back and forth, and we just want to be careful during this meeting that, you know, nearest appropriate is always payable if it's properly documented, and that is a separate realm.
Yes, yes, and absolutely, and that you're exactly right. I don't disagree at all. It is those time-critical diagnoses that, from a clinical standpoint, if what that patient really needs, for example, is damage control surgery by a trauma surgeon, and the nearest hospital does not even have a surgeon, well, then you're absolutely right. Then it's not necessarily appropriate to take the patient there. But yeah, totally agree that the nearest appropriate is always payable. And something else that you said, which I'd like to just kind of expound upon, which really resonates with me, is that you said that sometimes you would really have to depend on the ambulance provider to make that correct clinical assessment and then know which facility is most appropriate for that patient. And that's very true. You know, I always tell friends and family, if you're on vacation in an unknown locale and you ever want to know where the best hospitals are, just ask a paramedic, ask the EMT, where would you go if you or your family had this problem? They do know what the appropriate facilities are for heart attack, for stroke, for trauma. And I agree that we would have to depend on the bedside clinician in the ambulance to know where that patient needs to go.
Yeah, thank you. And I think from Linda's standpoint, if I can speak for her team, a lot of times it's not that part of it in the medical review, it's the documentation of that in the medical review that is really what's hitting, which again then, you know, kind of moves away from locality itself.
Yeah. But wouldn't you say that that is very much related to the locality question? Because like you said, we're talking about nearest, closest appropriate facility. And so the documentation really has to support the decision as to where that patient can go.
Oh, absolutely. I mean, I do totally agree that you can't just take them and throw them as 2 separate things. Locality is definitely related to nearest appropriate, key thing I want to make appropriate, right? Because if you had a hospital, a critical access hospital that does not have a cardiology unit, but that's EKG testing, doesn't have all these things, and they may or may not, but let's say they don't in this example, or they don't have a cardiologist available, you know, what is the nearest appropriate? Oh, well, now it's actually 80 miles one way and 70 miles the other way. So then, yeah, then we look at locality and you still have to figure all of that in. So I wasn't discounting that locality plays into it. I was just trying to, you know, clarify the difference. And
sure. Yes, yes. I totally, what you said totally makes sense there.
Other questions or comments?
Dr. Kettler, it's Linda. I was able to get my audio going here again. So I'm just curious, Dr. Tan, you know, I think data analysis and what we can look at as far as each of our jurisdictional regions, whether it's rural, urban, or suburban, and what we can find is really going to potentially be key and critical for us. If you had the opportunity to say, I would define the locality in my area based off certain criteria. We talked a little bit about diagnosis. What other criteria would you use? Number of hospital visits, number of office visits that are within an area, anything that comes to mind that you think would be beneficial in helping us look at the data as it relates to locality?
Well, I certainly think that a geographic area you would have to consider the number of options that the beneficiary has as well. I think that's one of the things you mentioned, correct? The number of hospitals.
Yeah.
In the greater St. Louis area, for example, there are actually almost over 50, I want to say, facilities licensed as a hospital. Now, granted, some of those are very specialty specific, like pediatric psychiatry only hospitals, but nonetheless is licensed as a hospital. But having said that, even just the general medical facilities, we are very spoiled in that we have a plethora of options, and our patients go to multiple different system hospitals. Contrast that with a rural and certainly a super rural area where the patient does not have nearly the number of options. I agree. You'd have to take that into consideration as well when defining a locality for a given geographic location. In the example that had been given, for example, if you have two relatively equal facilities, one is 5 miles away, one is 8 miles away, but the patient's physician is the one at 8 miles away, traditionally that had been covered as a covered benefit, which makes sense. So I guess the question would become, well, is there a distance at which it's no longer reasonable to go to another hospital, which is further away? I don't have a super good answer for that. I just know that I think some of it, a lot of it from a clinical standpoint has to look at what is the patient going there for, because certainly if it's for cancer care, for example, and they're having a complication of their chemotherapy or a complication of their radiation treatments, you certainly don't want to take the patient to another hospital which would have no idea how to manage the oncologic complications. So I find that when we kind of put the patient in the middle of this and kind of look at it from their perspective, it's a little bit easier to justify certain transport destinations, although admittedly it is a little harder to quantify on paper for regulatory purposes.
Thank you very much. I think one could easily argue that there's a lot of different data elements, a lot of different patient conditions, considerations to be given that really locality could have no end, depending on how one wants to present it. And so it really for us does come down to how good is that documentation and what is that ambulance personnel telling us so that we can best assess that particular claim when it is sitting in front of our nurses. So appreciate your input.
And this is something that I spend a lot of time with my crews on, is the documentation aspect. And I do let them know that this is way more than just billing, but it really is for the patient's benefit. And I would certainly invite any feedback to the physician medical directors who write these protocols and who determine what documentation parameters are required from paramedics and EMTs, because we can take this back to them and formulate some education to improve the documentation, makes your job easier, and ultimately is better for the patients.
Other questions or comments? Okay, well, thank you, Dr. Tan.
Thank you.
And then our last scheduled speaker is Ms. Allison Sundberg. Ms. Sundberg, are you on the line?
I am. I'm hoping you can hear me.
I can hear you. Please go ahead.
Thank you. And thank you for allowing me to speak to you all today. What I really want to make sure I don't do, I'm going to do my best to avoid a lot of redundancy with all of the comments that we've heard from the other group speakers, although some of them are worth repeating. I also want to stay as safe as I can on that gray area between locality and closest appropriate. I think we've had a lot of great conversation today to things that were really more closest appropriate versus locality, but yet, as everyone else said, they do kind of mesh in the center. So anyway, I'm Allison Sundberg. I'm the Market Director of Legal and Emergency Services for LifePoint Health, but mainly for UP Health System in Michigan. I do not have any conflicts speaking to you today. My agency is the largest EMS agency in my portion of the state, and we're also the largest county in Michigan. We cover about 3,500 square miles. So as you can see, locality is meaningful to me. My primary coverage area is very rural. We have there's 12 hospitals overall in our region, but 3 of those are in my main primary coverage area, in my 911 service area. 2 are critical access, one's a level 2 trauma center. And of course, as you can imagine, the services available at those facilities, those 3 hospitals vary greatly. I do not see one size fits all model for locality. I think it would be extremely difficult to apply. And certainly any quantification or definition of mileage would also be very difficult for us to try to comply with. I guess one question, and I apologize if I missed this early on, but is there any chance that you have already told the group why you're digging closely into the definition of locality? Is it time for that to be reviewed, or sorry to back up, but I was just hoping that would help define a little bit more of what I wanted to say.
No, we have heard concerns that our definition is, I should say, not appropriate for our jurisdictions.
Okay. Great, thank you for that. I think that does lead well into what else I wanted to add then. The current locality standards, they work in my service area right now, but they are starting to become in recent years following those locality standards, or I think what Mr. Slagle said about what our routine patterns might be. I think it was him. The services available both on the EMS and the hospital sides are now inconsistent on every single day. Staffing challenges, the ability for an ambulance transport to even be available, or for a hospital that may have had a service yesterday, maybe they had orthopedics or GI yesterday and today they do not. So those do affect my locality issues. I have one of my service areas. We do about 15 to 16,000 calls a year. Some of them have to leave the closest facility because our STEMI services are located 60 miles away. We have another area that we cover that their closest hospital, there's actually 2 of them about 12 to 15 miles away. But the paramedic has to make that decision. Is 12 to 15 miles and then a potential hour-long stay at that facility the right answer, or is going to the 40-mile away facility the right answer? I don't want to waste certain, time, as Dr. Han talked about. I don't want to waste on stroke, STEMI, or trauma an hour at another facility who may or may not want to get a CT or et cetera. I think that the discretion of the frontline medic is involved here too. And they need to make that decision that based on current patient condition, that it would be best if they treated them and expedited them to a more definitive location. And I don't think that we can black and white author that for those people on the front end. And of course, they have their medical control physician on the radio to help guide that. Michigan in the last year has introduced, they've had a trauma system of care program that's being built. It's come quite a distance in the last maybe 5 to 7 years. They're now approaching a system of care for STEMI and stroke as well. Those are very much in their infant stages, but they are also going to define a lot of our locality issues for us. And Michigan has some pretty solid protocols that have given us some specific medical conditions that we can transport, and we developed a regional destination matrix that all the hospitals contributed to. So what may on paper look like closest appropriate, and it goes back to what the physician also said, an adequate explanation in our either our EMS report or the hospital records really is the important part. The providers in those hospitals are helping support patients receiving any unexpected charges or uncovered costs by us going outside of that defined boundary. But as it's been alluded to a couple times already, we don't want patients to have those uncovered expenses or costs thrown at them. If we have to send someone to a higher level of care from our level 2 trauma center, that mileage typically can be 150 miles to 200 easily. And we have to leave the state. We will go, it's closer for us to go to Green Bay or Milwaukee. That is frequently done on the ground. Or some of our transports on the ground are 6 to 7 hours. And these are for higher level of care emergency patients sometimes. So it's really important that our physicians understand the documentation that they need to include, whether it's on the physician certification statement or in their explanation and in our narratives on our ambulance reports, that this patient does not unexpectedly get charged for the additional mileage. And the fact that those available services are changing every day makes it difficult. Staffing concerns, case by case physician specialties, cardiology, orthopedics, GI, urology, ERCPs, on any given day. And I think, again, Mr. Slagle said, they may have that coverage Monday and Tuesday, but then all of a sudden Wednesday, Thursday, Friday, they don't. Leaving our local coverage area to bring some of these patients outside of that private service area can leave dangerous gaps in coverage for us. We try our absolute best to assure uninterrupted 911 coverage while we bring critical patients to outside of the area. But again, staffing's an issue. Behavioral health crises, some of those transports for us literally take us 8 hours one way by the time we find a facility with an available inpatient behavioral health bed. And these people can be in serious crises in our emergency department. And it's just not something that those, not all of our hospitals are able to manage that. So not surprising is our biggest challenge is meeting our current patient needs with less availability of hospitals, healthcare teams, staffing for EMS, and the distance we travel being over 150 miles one way in some instances. And the physicians who are already short-staffed are getting overwhelmed with trying first to find an acceptable facility and then having to document when they finally were lucky enough to find an acceptable facility, then having to document why they didn't use facility 1, 2, or 3 that were closer. And of course, on the EMS side, we don't want to challenge them, but we're very aggressive to ask, why are they not going to facility X? And if they just say there's no beds available, well, there may have been no beds available yesterday all day and they're just not calling today. So I think we would benefit from clear guidelines of what that physician certification statement needs to include. Some of them are pretty weak when they just write down services not available here. That does not help us when we go through an audit and our transports are, the patient all of a sudden has a back balance or the EMS service has to eat that because of the time that's elapsed. So I think that the definition could be cleaner, but I also think it should be in some ways more subjective so that either the physician or the EMS provider themselves have some flexibility without any definition related to mileage. Again, closest appropriate for actual care is critical. I get that part. But the paramedic does have to have some discretion. And thank you.
Okay, thank you. Any questions or comments?
Hey, Dr. Keller, it's Tom. Can you hear me now?
Yes. Yes, I
I
can.
was kind of bouncing back and forth between muted, not muted, and wouldn't hold. So for the comment on the physician certification statement, and does WPS have something We do have a form. It was in our Learning Center, and I say was because our Learning Center is no longer available. It is being transitioned to our website. So that form is something that is a sample form. It's a sample physician certification statement. It is not mandated. It is not required. But what it is designed to do is to help anyone developing one, anyone who wants to look at it, to see what would really help WPS when a physician writes it, get that information in. So it definitely is something that's available. I'm not sure when it will be, republished to our website again, because we did have to, we're removing from one resource and moving it to another resource. But so we do have a sample form that you could look at and you could see, oh, okay. And this is a form that was developed from my team, one of our clinicians, and Linda's team, one of their clinicians, to meet both the education standpoint of it, but also key the medical review standpoint, and to make sure all of the components of a PCS are met. For right now, if you are interested in that, I would recommend dropping an email and we will get that to you. The best place to actually email that is, and I'm going to say it slow, so the best place to email that if anyone's interested is WPS.GHA.education@WPSIC.com, and just mention the sample PCS. We'll know what you're talking about and we'll get you a copy of that. I just wanted to bring that up because you had mentioned that you were having trouble exactly determining what's best to go at, and we get very generic statements sometimes that aren't the best, and this form was developed to try to help avoid or alleviate that.
I think they feel that it's redundant with what they've already documented to try to find an acceptable facility and being prudent with their Medicare patients' dollars, and then to fill out another additional form. But I mean, I'll be very happy to look at what you said is out there. I'm excited about that.
Also, in terms of redundant, if they have a generic PCS and and you can get their documentation for what they've done to get there, to get where they've chosen. Linda, correct me if I'm wrong, but don't we consider that as well, as long as it's sent with some form of a PCS? Then that may be, again, a Linda Oliver correction if I'm wrong.
Could you repeat that, Tom? I'm not sure I'm understanding.
Sure. So the doctor has a PCS and it says, this is the facility I want them to go to. Here's my generic reason. But on their actual notes, they say, we contacted these 12 facilities and this is the one that can take them. So that's why I'm ordering it to this one. But that's not all written on the PCS. We don't know that they've contacted these 12 facilities. Instead, that's in their medical record. Like, let's just say they're leaving the ER and the ER doctor has done this, or the counselor has done this, and they're trying to coordinate that care. We could accept, along with the PCS, a very generically written PCS, but we could accept the reason from the medical record as well, coming in from that facility they're leaving and why they chose that facility.
That is correct. As long as we will accept documentation that falls within the medical record, it does not, even if it's not written on the PCS.
I think, and I appreciate Linda's comment, but someone in the chat box did kind of solidify and maybe said it better than I did. The burden is on the EMS to make sure that the hospital's filling that PCS out. We certainly don't have time, again, due to staffing or even access. Nobody on a non-employed hospital EMS crew is going to have the ability to go through the medical record. And the hospital truly doesn't care what the rules are about our reimbursement. So it's very difficult. If the hospital was going to get billed back, and this is a very whimsical statement here, if the hospital was going to have to pay for transports that weren't covered based on their documentation, they might be more careful. But there's no way that EMS is going to, before the call and the transfer, review the hospital record for appropriateness on closest appropriate or locality, as the case might be.
Excuse me, other questions or comments? Okay, well, thank you, Ms. Sundberg. Now we're going to proceed Excuse me, just a minute. Now we're going to proceed to the public comment portion of this. This will be very similar to how we've been conducting things so far. If any member of the public who has been in listen-only mode to this point wishes to make a statement, you can use the raise hand icon or press *3 if you're using a phone to call in. And then Rich will release or unmute you, and you will be able to speak for 5 minutes. And WPS personnel may have questions for you. Prior to speaking, please identify yourself, your affiliation, and briefly state any conflict of interest that you may have. We will potentially take comments until 4 Central Time. It is now 3 o'clock. So with that, Rich, do we have any of the public that wish to make a comment?
Yes, we do at this time. I am requesting unmute. I don't have a name on this, but it's a call-in user with an area code 904. And I've just sent a request to unmute. So if you're able to unmute. Okay. Kent Vosberg, you may speak.
Well,
Go ahead.
my name is Ken Vosberg. I'm the EMS chief in Junction City Fire Department in Junction City, Kansas. I'm wanted to speak about the locality issue as it is near and dear to our heart. I have a hospital that is been bought out by a another hospital. So I have a hospital in our town. The next closest hospital is 22 miles away. Our closest level 2 trauma hospital is 45 miles away. And then it goes 60 miles away and then beyond that. My hospital is owned by the hospital that is 60 miles away and is routinely requesting patients to be transferred straight to that hospital 60 miles away, bypassing the closer hospitals. And we are fighting the locality rule daily. Like I said before in the chat box, they don't care what our rules are. We are pleading every day on these physician certification statements, asking them to fill them out correctly. Please expand more why they are bypassing this hospital or that hospital. And we're routinely being told, I'm the physician, you're going to go there because I'm ordering it. I'm the professional. This is the rule, you go. And that is what we're being left with. So, as you at the legislative and higher up, please understand, this is what we on the ground are dealing with. Thank you.
Thank you. Questions or comments from WPS?
So Dr. Keller, I just want to say that we do understand that, and we hear a lot the same comments that you're making about we can't get the physician, we can't get the hospital, we can't get this and that. It's not that we're not understanding or we don't have an understanding of that. We do have an understanding of that. There is a process in place, and unfortunately it is a time-consuming process, and it, requires the ambulance to bill in a certain method, which would then deny those mileage and give the patient the right. Even though you may not be able to say, I can file an appeal, the patient still has those rights. They can then work with their physicians to get that done, and that's on them. I understand it's not going to help you get paid necessarily if the patient, has a financial burden or is unable to pay you. But so when we look at it, we hear you, we understand that this is occurring. We also have a responsibility to look at and say, how do we meet the regulations? So, some of that is regulatory based, and we can't really work around that from what you're saying there. Because we do hear you, we do understand the frustration and the hardship of trying to get the PCS and to get the necessary information. That's one of the reasons we created the sample form.
Is Dr. Tan still on the line? I was just curious how, as a physician, he might respond to that, but at any rate, any other questions or comments from WPS?
Dr. Kettler, we had a comment come in from a lady who doesn't have a microphone. So I'm just going to kind of address it real quick, if you don't mind.
Sure, go ahead.
She said she's going back to the facility where the patient had a surgery, and then they're going to a different facility as an ambulance supplier. So does it cover the pass? Does the ambulance mileage covers the pass, or could they treat the even though they could treat the patient at a closer facility, though the surgery was done at a further facility? Again, if there's a medical justification for why you need to go to the further facility. So they had a coronary bypass, and the closer facility can't treat that. Even though they're having a complication, it's really not appropriate. They're not going to be able to treat them. That would be a reason to bypass. On the other hand, just because that's where their surgeon is or their care team was when they had the surgery, that's continuity of care, and that's not written within the regulation as such a reason for transport, is the way that CMS has stated that. Now, it has been questioned and back to them a lot. So when we look at locality, when we look at nearest appropriate facility, we can't look at continuity of care. Again, unless CMS gives us a different direction, which they have basically said at this point, we're still looking at it and we don't have a direction for you. So hopefully that makes sense when we look at that type of information. It would then be considered doctor preference to take them to the further facility or patient preference, depending on who's requesting it, and therefore not payable. Again, outside of the 5-mile locality in today's current jurisdiction.
Thank you, Tom. Any other questions or comments related to that specific comment?
So we have a further follow-up, and it says beneficiaries get to choose which Medicare facility they go to, correct? All hospitals in an area would be approved for a beneficiary living within 60 miles. Is their preference based on the Medicare approved facility? It doesn't seem Medicare would be further ahead if the beneficiary can choose a clinic provider who is part of a system more than 5 miles away. On occasion, they have to be transported. We require them to be taken to a system who has none of their information, so repeat testing, etc., would then play into it, driving up factors such as cost for overall testing. So it's just kind of a bit more there. First of all, the 60-mile rule doesn't really apply at all, even when you're talking locality in terms of what we have defined as locality at this point. So just because they're within a 60-mile range of this living, it's different. Now, if you said to me, I'm taking the patient home from a facility and this is X amount of miles away, key thing there is home. So it's a little bit of a different situation. So I don't want to make it seem like we don't ever look at anything like that. In terms of locality, we do use a 5-mile radius. So if you're taking them and the facility, again, that they had surgery that has all of their medical records, et cetera, is 20 miles away, but there's one that's only 8 miles away, Medicare will say, hey, we will pay to the 8-mile one. We're not going to pay to the further one because it's outside of that in terms of WPS's definition of locality. So again, that 60-mile range you're talking about, I'm not I'm not familiar with where that came from or anything like that. So in terms of, again, continuity of care, who has the records, all of those different things, it's a different information when you look at locality and how it's defined.
Okay, thank you. Rich, anybody wishing to speak?
Yes, we do have a couple more hand raises. There was one more question that was asked in the chat earlier during the panelist presentation, and maybe this has been answered piecemeal through the meeting, but the question is specifically, would WPS please clarify the specific processes they use to determine closest appropriate hospital?
You
Hi,
know,
Dr. Kettler.
oh, okay, go ahead.
I was going to say, I can answer that. So in order to determine what services the facility has to offer, we look at the American Hospital Association website, and we look there to see, do they have cardiology services? Do they have neurology services? And so forth. So that's a very brief answer to your question. If you are looking for additional information and want to submit an inquiry, we would encourage you to do so, but we do use the American Hospital Association information as it relates to their directories and what facilities have to offer.
Thank you. Rich?
Yes, we do have a hand raise again from that 904 area code phone number. I'm going to request unmute, and hopefully they will have a chance to speak this time. Okay, the area code is 904-234, and the rest of the phone number is muted out. There we go.
Okay, can you hear me?
Yes.
Okay, sorry for the technical issue. This is Curtis Lord. I'm a consultant with Global Medical Response and other companies. I do MAC liaison work for healthcare providers, and I have no conflict of interest. I guess the problem with going at the back of the line here is everyone has said everything I was going to say, but I will repeat that we certainly believe that locality should be defined the way CMS defines it, which is the area within which beneficiaries normally travel or are expected to travel. So wanted to restate that. And also the 5-mile rule is somewhat problematic for all the reasons the commenters have mentioned, the variation in geographies, the complexity of the healthcare system, the difficulty it could create for beneficiaries in terms of out-of-pocket billing. So wanted to reiterate that. Then, then the only other thing I wanted to say was, I think Dr. Kettler was right a long way back when he said we seem to be confusing the locality discussion with the nearest appropriate discussion. And, frankly, I have a hard time getting my head around that. I find myself asking, are we trying to define locality so that if we do, all the facilities within that locality could potentially be covered destinations? Or are we, once we define locality, still going to apply a nearest appropriate facility rule? I guess that's a question back to y'all.
I guess one thing that, well, to answer your question, I think we are looking for the input of the stakeholders here to help us determine the definition of locality. Going back to what you had said, and, I understand what you're saying about the definition in the Internet-only manual. How would you implement that definition?
Well, I'll tell you how I did implement it. As you know, I was the CEO of a couple Macs back in my younger years, and this is all we did in Florida. Just to give you one example, given that a very small percentage of the ambulance claims are even looked at on a prepay basis, if things haven't changed dramatically, I'm going to guess it's a small single-digit number. But given that that's the case, we didn't use a mileage number to try to define locality. We used a mileage number to define what was likely beyond the locality. So, we were in a position to say, as long as the transport was less than a certain number of miles, and you got to pick that, we're going to assume it was to an institution the beneficiaries normally travel to or are expected to travel to. But if we see a claim with more than that mileage, we're going to suspend it. We're not going to let it go through. And then we're going to do the hard analysis of whether, the person was appropriately transported. And then on audit, what we used for locality was simply to say, not a mileage rule, but just to say, did the person go to a hospital that makes sense, given the situation that was present? Did he go to a hospital that beneficiaries would have been expected to be transported to? If yes, okay. If not, not okay. But so again, using a mileage number to define what is likely beyond the locality, not what is the locality. That's what we did in Florida many years ago, and it worked good for a couple of reasons. It also allowed us to suspend the claims that might have otherwise gone through and paid that clearly had too much mileage on them, in addition to looking at claims on audit when that was the right thing to do. So that's how I would do that based on my past experience. And you have a lot of data analytics that could help you identify what that likely beyond the service area is on a rural, urban, and suburban basis. That Matt guy, I think was his name, he could probably crank out some good data for you.
Excuse me, I'm just trying to better understand. I'm not sure, setting aside a specific mileage, not sure I see a difference between what you did and what we're doing. Could you maybe enlighten me on that?
Yeah, we didn't use the mileage to say that's the definition of locality. We used it to suspend claims. And then when we looked at those claims, it could have been that it was okay that the person went 30 miles. We weren't denying the claims. We were just suspending them to look at them. So we were just using the mileage as a screening edit, not as a definition. So we weren't creating a bright line, 25 miles is all you get. We were saying at 25, we're just going to take a look. It may be okay you went 30. It may be okay. It may not be okay that, you went 30, but we're going to take a look. So it's just a backward, it's a way of backing into it, I guess. Rather than define locality, you suspend claims that might have gone beyond the locality.
Okay, thanks. Any other questions or comments from my colleagues at WPS? Okay, thank you, Mr. Lord. Rich?
Thank you.
Yes, we do have another comment or question from Gary Miller, who previously spoke as one of the panelists. He's got his hand raised. Gary, you're free to speak.
Yes, I highly agree with the previous caller. I think he hit it head on with that. But I just have a general question is, from my understanding, CMS allows WPS to set the locality. My question is it appears that everybody is having trouble with the 5 miles. I am curious how you came upon that 5 miles, because it does seem very restrictive. And I'm also curious if you have checked the other payers to see what locality definitions they use.
I can answer that. The definition actually predates everybody on this panel. So not sure exactly how that was arrived at. We have checked with other MACs, have not looked at commercial insurers. And I think it would be fair to say that they're struggling as we are. Some have maybe a different mileage, but I don't know that any of them really have an answer either. I don't know if that answered your question, but that's what I found out when I talked to my colleagues elsewhere.
That did answer my question, and I do have experience from billing way back, and I'm talking 40 years ago, and previous Mac actually. And I do believe that they had used 40 miles in the past, but I could not find any documentation of that, but that's what my memory says.
Just
Dr. Kettler, just to add to the
sure.
Actual mileage basis, we do have one of the speakers who did say that, there was a recommendation for looking at a specific set of mileage beyond locality, so saying 40, 50, whatever it was. And how will that affect, and he's saying, that would be very detrimental to something like a rural area where, how do you distance that? And I think that's what we keep coming back to with locality, if I'm not correct, is how do we distance, the locality for that when we say, okay, we're going to look at 40 miles, and if anything over 40 miles, it's kind of a random number, but we're going to then suspend the claim. Well, that would, I think what this person is saying is would be detrimental to the people who are actually billing correctly at 60, 70 miles because they're in those rural areas. WPS used to do that. We used to have a mileage edit that, we started very restrictive and went out into a variety of different standpoints. And how did we then, and what we found is that as we were hitting those edits, we were actually getting the people that were billing it correctly more often than we were the people that weren't, which became very burdensome for some of the providers. Again, don't know where the 5 miles came from, that I can't answer, but I just wanted to share a little bit about that history.
I do have a follow-up question then. And I think you're going to have this problem with any mileage if that's the criteria you use. But in terms of recommending 40 miles, I think that makes sense in a rural jurisdiction or a rural area. But in urban transport, that strikes me as something that could be subject to abuse. What are your thoughts on that?
Who is that question for?
I forgot the speaker's name, but it was the person who suggested a 40-mile definition of locality.
Okay, that's myself. That's Gary Miller.
Okay, sorry.
And similar to the previous caller where you would, I really don't see much abuse happening in the urban areas simply because most of the places are really going to be using their standard protocols for where their destination is going to be. In those rare circumstances where you're going to be taking somebody 35 miles away compared to 2 miles away, in an urban area is not that great of a occurrence. It doesn't happen that often. As far as it being detrimental to the more rural areas, again, with the previous caller, he mentioned, well, you just use that as a guideline to say, okay, because it is a higher number than 40, these we want to take a closer look at.
Thank you. Any other questions or comments? Rich?
Okay, All right, Allison is stating in the chat, I also don't see much abuse in rural areas as EMS services do not have the bandwidth staffing-wise to choose to go 40 plus miles away unless medically necessary. And I do not see any other raised hands at the moment. Just a reminder, if there are people who are on a telephone only, you can press *3 and that will signal the raise hand icon for me and I can unmute you. And I am seeing no more raised hands.
Okay.
There is one. There is one.
All right.
This person is labeled KB. I've just requested that you unmute your phone.
So my name is Kira Bell, and I am SVP of Revenue Integrity for a billing company, a nationwide billing company. So we have transports across the nation. I wanted to comment on locality, though, and specifically to the definition that was read at the beginning of this that says, with respect to ambulance service, means the service area surrounding the institution to which individuals normally travel. So I feel like we're setting the locality around what WPS has defined as the closest appropriate facility. And I feel like that's a bit backwards. In the example from CMS, it talks about a small community hospital, which has 35 beds, and then 2 larger metropolitan hospitals. Each of those 3 hospitals receives patients from the community. Therefore, the locality contains all 3 hospitals. But what I'm seeing is that when we have, let's say, a large metropolitan area, like Dr. Tan was talking earlier in Missouri, in St. Louis, well, just over the border, maybe, 8-10 miles, there are many local community hospitals. But those patients may go to a larger medical center within St. Louis rather than their local community hospital. So their local community hospital may be 2 miles away, but going into St. Louis may be 10 miles total for them. So the drive isn't really that much difference for them. But what we're hearing is that the local community hospital would be the closest and most appropriate. And so these patients can't be transported another 8 miles without the patient getting a bill. Yet CMS describes locality as the service area surrounding the institution. So I'm not sure how we can get back to then these major metropolitan areas and these patients, these communities that are using those as being part of a locality, rather than just stating, well, these 3 hospitals are within that entire locality, but if you don't go to the one that's closest to you, even though it's within the locality, we're still not going to pay for that mileage. Thank you.
Dr. Keller, I have a question or a comment as back to that. She brought up a very valid point in terms of urban, right? We understand that, you're coming into St. Louis, there's a variety of facilities. Yes, they're this close. Okay, fine. What do you do then for a locality or a normal service area, and how do you measure that for something that is, again, going back to the rural, going back to the critical access, going back to those types of things where it is 40 miles difference, 50 miles difference, and a patient may choose one over the other. One may be, a greater distance, and it could be, again, 20 miles difference even. So when you look at locality, we here at WPS struggle, just like the providers do, just like you guys do, with how do you define that in terms of both urban, rural, and super rural, which we have within our jurisdiction.
I don't know that that specifically needs to be determined by a set mileage, rather than looking at the institution itself and gathering data from there as to where is the community coming from. So how far are community members coming to that specific institution? Now, if you have the majority of them are coming within 60-mile radius, and you have, 2% that come, 30 miles past that, I don't know that I would include, that 2%. But if the majority is coming from this defined radius from the institution itself, that should be considered the locality.
Okay, and so that I'm not disagreeing by any means based on what you're saying, so please keep that in mind. So we do have a process. Medicare has a process in place that if you disagree with the locality, by this definition, you could take it further and you could go through the appeals process. I'm not saying it's the most cost, and I'm not saying any of that. I'm asking when should we be defining it, and how should we be defining it versus having you guys prove it through the appeals process, and you being the ambulance supplier or the patient, because either one has the right to do the process.
And I agree with that, but I shouldn't have to prove why I went past a closer facility if the facility that I did end up going to is still within the locality.
And can you define locality in a meaningful way other than to say, go out across the board, spend a lot of money, Medicare funds, to determine this, which then kind of defeats the whole purpose all over again, because you're spending, in terms of a MAC, a lot of money to define your locality for each specific service area within all of our states. That's the struggle that I hear you. I understand what you're saying. There also has to be a point where you look at the Medicare trust fund and when does it become cost prohibitive. And again, it comes back to some of the fact that we used to have a different definition, we used it differently, and we did medical review differently. And CMS found that to not be a cost-effective way to do that. So I'm just asking for suggestions, if that makes sense. I'm not trying to be argumentative.
Sure,
I'm just asking for suggestions.
Yeah, no, I absolutely understand. So I would just ask, because you said that WPS used to define the locality differently, and now you're defining it as the closest appropriate facility, but you're not stating within a locality. You're just saying it's the closest facility, and then 5-mile halo around that. So it sounds to me like we're again mixing closest facility with locality.
So the difference was, before CMS puts in the verbiage that the MAC has the discretion to define a locality in their service area, WPS did not define locality ever. We went straight nearest appropriate facility, period. Because that had no meaning. Like, we don't know what that means, and we were asking CMS, and I'm not kidding you when I say we were asking CMS almost annually, can you help us with this? 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 What do you want by this? What does this mean? How do we do this for a jurisdiction? And in lack of direction, we chose to use the nearest appropriate facility. So when I say defining locality, I guess I should say we didn't use locality based on the fact of the very vague definition. Because again, surrounding a facility means what in certain where you have different varying items, the west side of Kansas versus St. Louis, Missouri versus Kansas City, they mean different things. And so how do we quantifiably but still be cost effective with it? And CMS could not answer that. And that's where they came up with the MAC has the discretion. So that's what I'm asking you is, it sounds great to say, put this in place and do this, but how is that a cost effective way to do that?
Well, how did WS define the current locality of closest appropriate facility plus 5-mile halo? I guess I'm wondering,
Again, that's what we're looking at, and that's where we come back to the fact that none of us have that history. I don't have that. None of us have that history, and Dr. Kettler said that already. So I don't know, and that's what we're trying to get to, is a way of looking at it differently.
I think that the locality is quite defined in CMS as the surrounding area of the institution, and then there is a separate definition for closest appropriate facility. And I do think that those are getting misused or sort of blurred together. I think that the locality is one thing, and that is where patients go to get their services, so medical services. And I think that if we start arbitrarily assigning, what we, certain distances, then that is really putting a burden back on the patient, and basically saying that, we can't do, I guess what I'm asking is, are we saying to the patient that you don't have the ability to determine where you want to go and get your health care from? So if you typically go to hospital A and that's 8 miles further, you cannot choose that unless you're willing to have a financial burden. And, I think that we all can agree that, patient billing is not 100% paid. And so it really is the ambulance provider that ends up having a loss. And so it's just more to think about. Obviously, I'm not here to solve it, obviously, but I think it is interesting that what other MACs are coming back to you saying, and maybe looking at their edits that are in place and seeing where they're set to. And then also, I'd be curious to know, is this an issue that you have encountered, or is this one that you're more trying to prevent with this mileage to more distant facilities?
I guess one thing that I just want to clarify, and then I think we should move on, but what you would recommend then is that we get data from hospitals that indicates where their patients are likely to come from. Is that what you're recommending?
I think that that would be one part of what should be reviewed, one part of the data analytics, yes.
And what is the other part then?
I think going out, as was previously recommended during this call, from the different state associations, different EMS organizations that gather such data, I think that would also be helpful. But I do think that gathering that data from the actual institution and their radius would play an important role in this as well.
Okay. All right. Thank you.
Thank you.
Rich?
Yes, we do have another raised hand from Mike Ross. Mike, I have just requested to unmute you. There you go. You're free to speak.
Can you hear me okay?
Yes.
Yes.
Okay, thank you. Yeah, I think you're headed the right direction with the previous person that was on giving an opinion about data sources. I work the ambulance frequently myself. I also do some in-house closest appropriate reviews, actually doing some today. Trying to, again, figure out what, you guys think's appropriate through the MAC. And I know that there's, confusion at all different levels for that. So, and I understand that you're using the AHA Hospital Association directory as a resource. Probably not the best resource for what hospitals can and can't do. I would imagine there's a lot of inflated egos sometimes on, that we have cardiology services when cardiologist shows up once a month. So I'm going to make a couple of suggestions, not to just complain and about a problem, but I agree wholeheartedly with the previous person about marketing data. Each hospital should have referral pattern data on zip codes where patients come from. And I think that would be extremely helpful to overlay that with the ambulance services area. For example, if I have a zip code that has X number of patients that actually come from that zip code and travel to that hospital, then I should be given some leeway on mileage to transport those patients to where they want to go. I also would think that some of my current billing data on where I transport patients would be helpful to overlay into that on what destinations I'm currently taking patients. The other thing is my third category would be acuity. The one thing that I see that is extremely inefficient in what we do is taking patients that are essentially urgent care type patients to the hospital that they want to go to just because they've been told your records are here, my doctor is there. There's some marketing on the ploy on the part of some hospitals to get people to return even with low acuity issues to seek further services. There's no reason at all to drive someone past a local hospital that's short of breath with no other comorbidities that just needs to be seen in the emergency room to go to the hospital that they want to because that's where the records are. So I think acuity would be a play in there also. Again, these patients are motivated for their destination through brand loyalty, patient care records being on file. And I also, none of the patients actually know that they're going to receive a bill if they don't go to the closest appropriate facility or within the locality. So, and that's not a conversation that we're having with the patients. You know, we're taking them where they want to go and then just letting the cards fall as they do. But I think that there is data that's currently out there that would be low cost to begin to build a database that would be helpful in seeing what the transport distances are for some of these patients. And again, overlaying that with some acuity data would be helpful in determining what's appropriate. That's all I have.
Hey, thank you. You said that you felt that data is available, readily available. I forget exactly how you phrased it. Do you know how we would get that?
Each hospital should have referral pattern information on where their patients came from by zip code, just in their billing department and through admissions. You know, we got 25 patients from XYZ zip code in the month of June. Would be information that I would think that admissions would have, if not billing.
Okay, thank you.
You're welcome.
Rich?
Currently, there are no raised hands out there on the internet. So again, *3 if you're from a phone, or just press the raise hand icon. Okay, and I'm not seeing any raised hands.
Okay. Well, with that, it is 3:45 Central Time, so I think we will wrap things up. First of all, I want to thank all of the commenters, the scheduled commenters. I thought they gave us a lot of information and opinions to think about. And we do appreciate that they took the time to prepare and present us with those thoughtful comments. Also, I want to thank those who were not scheduled and provided the public comment. Want to thank my colleagues on the panel here, Mr. Tom Ryan, Mr. Matt Davis, and Ms. Linda Oliver. And then finally, I do want to thank Mr. Richard Staley. He worked very hard both to put this together and also carry out the logistics of this meeting. And without Rich, it wouldn't have happened. So with that, I'm going to close things and say goodbye.